Good evening, everyone, and welcome to tonight's webinar called Unexpected Scleral Lens Complications. Our presenters are Dr. Karen Lee and Dr. Maria Walker. Dr. Karen Lee graduated from optometry school from Indiana University in 2013. She then went on to do her residency in cornea and contact lenses at the Southern California College of Optometry. She now works at the University of Houston as an assistant professor, where she treats and manages a broad spectrum of patients with assistance from third and fourth year students. Before that, she was a provider for Boston site Pros Lens. She has published numerous articles on GP lenses, scleral lenses, and anterior segment diseases. She's also lectured dozens of times domestically and abroad on specialty contact lenses and anterior segment disease. Dr. Maria Walker attended the New England College of Optometry in Boston, Massachusetts, where she earned her Doctor of Optometry and Master of Vision Science degree back in 2013. She went on to complete a residency in cornea and contact lenses at Pacific University. After residency, she joined the faculty of the University of Houston College of Optometry as a visiting clinical faculty member. She's currently a part-time faculty at that university, where she is also pursuing her PhD in scleral lens effects on the eye. Dr. Walker has extensive experience with specialty contact lenses and has lectured and led workshops on scleral lens fitting around the world. Her main interests include contact lens optics, corneal physiology, scleral contact lenses, multifocal lens performance, and presbyopia and myopia control. Dr. Walker is currently the treasurer of the Scleral Lens Education Society. And with that, I will turn it over to Dr. Walker.
Great, thank you, Dr. Biondo. It is both Dr. Lee and I's pleasure to be with all of you tonight. Both her and I do some work with some of these companies. You can see many scleral lens companies. Nothing in this lecture will directly relate to any specific product. So we're here tonight to talk about scleral lens complications, and you can see here is a very non-exhaustive list of some of the complications that we see both with the lenses themselves and with the fits and with the underlying health. Now, we won't really be focusing as much. We'll go over these in the beginning, but we're going to focus on some of the complications and issues that we see maybe not as often, or we don't quite expect them the way we would some of these on this list. But before we do that, let's just go through some of these more common complications, and we'll really just touch and go on these because they are pretty common, and so these are probably discussed a lot more, and you see them with other types of lens. So first we have the application bubble. That every new patient goes through the learning curve. I just had a patient the other day who kept getting bubbles, and then you'll see him back in, a week or a month, and that sort of goes away. So that's an application error, and really you just remove, reapply, and educate patients when you see this occurring. Now, you're also going to get surface deposits like you would with any type of lens. So when you see those, you're obviously going to use adjust their cleaning regimen, as well as their eyelid hygiene, makeup hygiene, things like that. Same kind of thing with this. You can see on the upper right hand corner we have a non-wetting scleral lens, another really common, usually early on in the wearing process complication. Good technique and education about cleaning and taking care of the ocular hygiene can help you a lot with these issues. Stuck on lens, again, these are all those newbie issues. It's really just a technique thing here, and so you can instruct them properly on how to remove the lenses, which we won't really get into here. We're also going to run into some common fitting complications. So you can see in this bottom right-hand corner here, a classic appearance if the lens is touching, and certainly if the lens is moving a little bit and it's touching apically, you're going to see some breakdown. Let me see if I can get my mouse, which doesn't work. That's okay. You guys can see it. Bottom left-hand corner, that's clearly an apical touch and some breakdown of the epithelium because of it. You'll also get limbal bearing, like you can see in this middle picture, where that fluorescein pattern is going to be very dark in the limbal area. We'll actually discuss in the case I'm going to talk about today, we'll go a lot more into this limbus and what's going on there. So we will talk more about that one. Conjunctival blood vessel impingement, you can see in the top right-hand corner. Again, a pretty classic issue, which is caused by the lens being too steep or bearing down too much. This can get tricky when it's only in one little spot, but that's something that you would flatten, and if you can, flatten in just that area. And then you have pinguecula impingement. Of course, you can make some lens design adjustments. So pretty much all of these types of complications are going to be modify fit as the main troubleshooting. Now, again, looking at some of these more, getting into the more, a little bit more complex complications require just a little bit more thinking on our part. We've got midday fogging, where you get the debris that accumulates in that tear reservoir. Here we've got lots of little tricks that we can use. We can modify the fit, change up some of the cleaners and some of the application solutions, work with the patient on lid hygiene, mainly trying to reduce the, meibomian gland dysfunction and debris and eyelash debris, things that are going to get trapped underneath that lens. Conjunctival prolapse, this middle image, you can appreciate there in that inferior quadrant, you've got conjunctival tissue that gets kind of sucked up under the bottom, under the peripheral edge of the lens. For this, we're modifying fit. Usually I just monitor with these patients, as long as it's not more than a couple of clock hours. You're going to get preservative toxicity. This is, seems straightforward, but, just these little details and missing these things, patients can, have this chronically and not be super symptomatic, but then the ball will kind of drop and then they'll be very symptomatic. So important for us to pick up on these sorts of things, this preservative toxicity. You may not even pick up on this unless you actually take the lens off and stain it. Because sometimes it's just an appearance of the cornea, but then if the patient has it for a long time, they can have ocular health issues. So cleaners, technique, medications, not putting medications on within close proximity of putting the lenses on. I usually have patients wait 5 to 10 minutes just so they're not trapping that preservative from the medicated drop underneath. And then we've got conjunctival inflammation, which can be managed using the different cleaners and, of course, by managing underlying disease. So again, these are going to be your more common complications. Here's that list again. But like I said, we're going to talk more about some of the more uncommon. And we won't even go through all of these, but this is just kind of a list of things that good to have in the back of your mind when you're troubleshooting some of the problems. But we will go over at least a few of these. So let's do this through cases. So I'm going to do a case, and then Dr. Lee is going to do a case or two. We might jump in and say little things here and there. I know I peppered in a couple more common complications in between her and I's cases, but I'll go through this one, then we'll give a little bit of time for questions and then go through from there. So this first case is a keratoconus patient, 22-year-old Hispanic male, new to scleral lenses, wearing them for 1 week. So he comes in complaining of a reduction in comfort towards the end of the wear cycle and slight discomfort after the lenses are removed. So not hugely uncommon for patients to come in feeling like that. Usually when they first start wearing the lenses, they are going to feel the lens a little bit more towards the end of the wear. Things you have to look out. I'm already thinking, I hear slight discomfort at the end of the day. I'm thinking maybe this lens is tightening up. Maybe they're not getting tear exchange. There's a lot of things that can be going on, but certainly we do see in a lot of patients some sort of change in comfort towards the end of wear. So if we look at the ocular history, of course, keratoconus, new to scleral lenses, no interfering ocular meds. So if we actually look at the fit, we have, you can see in this right-hand column here, 400 microns of apical clearance, that's AC. The limbal clearance is aligned 360. So when I say aligned, I mean presumably not touching, but getting pretty close. And then mild bearing in the right eye and grade 1 bearing in the left eye. And when we say that, we're referring to the actual landing zone, which is where you'll see bearing by impingement of blood vessels. This guy's wearing them 15 hours a day, not uncommon. He's using unique pH and Puri lens to clean and apply his lenses. His VA is pretty good. IOPs are normal pupils. So taking a look at his right eye, looks pretty good. I might be able to, I might say that there's a little bit of blanching in that very kind of peripheral area. It just looks a little pinker as we get closer to the limbus. Not that uncommon to see this, and we'll see what this looks like once the lens is off. I wouldn't draw a ton of conclusions from this picture alone. I want to take the lens off and see what it looks like. So here I take that lens off. Okay. Still, to me, this doesn't look horrible. This picture shows, you can see the impression ring where the lens was sitting. You're going to see an impression ring, even on many of the well-fitted lenses. I constantly will hear people say you should get no impression ring, but I think that's a pipe dream for a lot of patients. You're going to get something. So this, as long as it wasn't too red, I'd probably say, okay, fine. We'll go back. This limbal area looks a little mottled, a little blotchy to me, but let's look at the left eye before we go back to this right eye. So this eye, to me, looks a little, just looks worse than the right eye. It's the same kind of pattern of appearance, right? You have that white, very edge where, you can definitely see some blanching there, some areas where the blood vessels are not smoothly going under the lens. They're interrupted a bit. And then you've got this kind of pinkish tissue. And this is something that that we can actually see quite a bit with these scleral lenses. So it's not uncommon, but not necessarily something that we would expect or want to see, is that sort of pink next to white appearance. So let's take that lens off. So we take the lens off. Here's the nasal view. So clearly this guy has at least a mild pinguecula. You can see that kind of hot spot of staining nasally there. Not very uncommon. Let's take a closer look at our limbus, though. So if we look here, you can see that we have this punctate staining. Some positive staining, some negative staining. It's a little bit hard to appreciate in this tissue, or in this picture rather, but if you look at the right-hand image, you can see that it's just not very well focused. And that's what that looks like when you've got some edema in that perilimbal conjunctiva. So there is some edematous tissue. You can see, when that fluorescein sort of is diffuse and kind of fluffy looking like that, that usually means that there's some edema. So we've got this hyperfluorescent edematous perilimbal conjunctiva. And then I could not capture this on camera. The camera I was using for this wasn't super high resolution, so we couldn't get it. But they have this sort of cystic appearance on the retroillumination. So that brought me to a paper that was published last year that I remembered reading about. And to be honest, this finding, this limbal kind of hyperemia, positive, negative staining combined, is not something new, and I had been seeing it on some patients. Not really that symptomatic, but you take the lens off and you see it. And sure enough, they had some mild limbal interaction of the lens with that limbal cornea. So here's the paper that came out from Alex Nixon and our friends up at Ohio State last year. And what they showed was that in these patients, and these are normal patients, these aren't people with diseased eyes, they would have this mild limbal touch, and then get this punctate positive negative staining. Now their pictures are much better than mine, part of why I wanted to put these on there. But you can see they really got a nice photo of that cystic appearance on retroillumination. And so if we kind of go back to the other eye, the right eye, we had a little bit of this too, where we had this limbal edema, which if I zoom in here, but even show you here, that's that same eye, where you can see just like in the left eye, we had this sort of edematous hyperfluorescence appearance overlying that limbus, very similar to what was reported in the Ohio State paper. So what is our diagnosis on this patient? And I call it limbal edema, which sounds really scary. I think it probably in the short-term acute setting, these patients are not particularly symptomatic of it, but it is something that is worrisome to me. And so the solution is really a fit change. But let's talk through that a bit. So if you're thinking about diagnostic considerations with a patient like this, the first thing I always look at, and this goes for most of the complications I see, is cleaning solution, because I want to rule out that before I go making any big changes to the fit or worrying about some of the more complex, trickier to manage scenarios. So I look, he's using unique pH and Puri lens. Okay, that's about as sensitive solutions as you can get. Maybe we could change him to a peroxide solution, but okay, I've thought about cleaning solution. I'm looking at the fit. I'm seeing some limbal, where it's getting pretty close to the limbus. So I sort of just skip to that, and I'm looking at fit. And really, this was a tight lens with limbal touch. And so I made my decision based on this. Now I have tear exchange and hypoxia here too. Those are things you got to think about, right? Because tear exchange, if you're not having good tear exchange and you get this metabolic waste buildup, sure, you're going to see some breakdown. You might see some edema. You'll see this non-specific inflammatory response of the cornea. Now, the fact that I was only seeing this at the limbus and the rest of the cornea looked clear, I think, okay, it's probably not tear exchange. And then hypoxia, I do want to just talk about hypoxia for a moment, because a lot of these, hypoxia is sort of a diagnosis that, the cornea is going to respond to hypoxia in a lot of the same ways as it will to inflammation and mechanical interaction, or at least it will mirror the same response. And so I think it's important to just kind of look at that. Before we do, and we'll talk a little bit about hypoxia in a moment, so don't ask questions about hypoxia yet. Does anybody have any questions about that limbal touch or about the slides so far? No?
So one of the things that I think about too a lot of the times when I see just general complications, really, it's mind-boggling how many of them are just application and removal related. Even like lenses that look really tight, when your patient puts it on, if they're shoving it on their eye, they can really make it look falsely tight. Or if they're removing and they're literally like almost pulling their eye out because they're putting that plunger in the middle, that's really kind of damaging to the tissue as well. So one of the things I like to do at every visit, especially when they're new, is just kind of watch them put it on and watch them take it off. And it really gives me a lot of insight as to what the patient's doing at home every day. Or if they're one of the midday fogging people, it lets me know what they're doing like 3 or 4 times a day, depending on how many times they're actually removing their lenses.
Okay, good. So let's just talk quickly. When I first looked at this and you see that patient and you see this retrobulbar kind of microcystic appearance, you have to go through, I think it's important to go through what that could be. And so when I saw this and started looking it up, I was saying, okay, is this PEE, right? Punctate epithelial erosions, or are we dealing with epithelial microcysts, or is it epithelial bullae? And so you can see here's images of each of the findings here. But I sort of dug a little bit deeper at these epithelial cysts. So even the microcysts and the bullae. So you can see this is a picture of microcysts by Kogan and Donaldson, probably the very first histological representation of a microcyst. So what these are, they originate in the basal layers, they migrate towards the surface, they'll stain with fluorescein, and then basically when those turn into bigger lesions, that's really when we call it bullae. The point I want to make here is these microcysts and these bullae, if they're true microcysts and bullae, they're going to really be signs of hypoxia. They start posteriorly and they creep toward the surface. So I think when we see these sort of cystic looking cystic looking bubble type of appearance in the limbus, which we really do see in these patients with limbal touch, we need to be careful that we're not falsely categorizing this as a microcyst or a bullae, because those really are hypoxic concerns. And if it's not hypoxia, which can be easily tested by doing pachymetry, that's really not the right etiology. And so for this patient, just to round it up here, their scleral lens fit looked okay. Limbus was aligned, quote unquote, but really it appears that it was touching, and we went and did OCT, and it was in fact touching. So we said it's unlikely to be hypoxia in this. We did pachymetry, did not find a change. This is more of a mechanical issue that maybe is going to mimic the hypoxia. So what's our diagnosis? Limbal disruption, that's what I call it, due to mechanical interaction of the scleral lens. And this quote is taken right from Alex Nixon's paper, and I totally agree with him. Weakening of the tight junctions between the epithelial cells, allowing fluid to kind of percolate into the extracellular matrix spaces. And then we are also going to get this overlying inflammation of the conjunctiva, but it's mechanically driven, and the key here is to not touch on the limbus. So we had this limbal touch peripherally. What did we do? We increased the amount of limbal clearance. In this case, we also increased the lens diameter because creeping back, you remember from those pictures, we had some impression of the conjunctiva as well, a little bit outside of my comfort zone. So I increased the lens diameter in this patient to get the landing a little bit more evenly on more conjunctiva. So in general, for this patient, management and considerations, we checked the solutions, care, handling, stuff that's easy to change first. Then we look at the fit. Now, if we hadn't found a fix or a catalyst with that fit, I would have gone on to evaluate tear exchange. We did actually look at edema, but that could have been explored a little bit further if we were really chasing our tail. The summary is, don't always jump to these hypoxic etiologies, especially with, if you're seeing it only in one little area where the lens is also touching. This was a mechanical event. Now, since I do love talking about corneal edema so much, I'm just going to touch on that for a couple of slides here before we ease into some other cases. Corneal edema, lots of papers published on this. We don't really see it with a huge frequency clinically significant, right? We don't have a lot of patients running in telling us that their vision gets really blurry throughout the day and that we don't see these hazy corneas. But it is something that we do need to watch for, and if you do watch for it, you will see it. Here's a couple of examples. This is a patient, their pre-map is on the left, their post-fitting, couple months post-fitting here is on the right. You can look at the numbers, they match up to the same corneal location. So if we look at the difference map, which is here, you can see that there's a difference of as much as 150 microns, 151 microns of increased corneal thickness after initiating scleral lens wear. So a lot of swelling in this patient. And this was a transplant patient. So you can see a lot of that swelling is occurring right at that graft-host interface. So this was a patient who was asymptomatic. So in these patients, important to watch for this, important to do everything you can, increase the decay, reduce that tear reservoir, increase tear exchange. What else do we have, Dr. Lee?
We're going to talk about this in case like 3, I think.
All right, good.
Yep.
So we'll go more into this, but there's lots of things you can do to manage corneal edema. At the very end of the road, sometimes you have to limit the wear of the lenses a bit, remembering that these are diseased eyes. And so you have to, you're managing the disease as much as you're managing, if not more than you're managing the actual lens fit themselves. Let's quick look at a keratoconus patient. So this is a patient who you can see, if you're just looking at the color map, doesn't look that much different. If we look at the difference map, you can see within the pupil there, you've got 20, 30 microns of swelling. That's within the normal range. You're always going to see a little bit of an increase. What strikes me about this patient is if you look inferiorly, they've got, 90 microns of swelling, 70, 75. And so you've got this area outside of the pupil where the patient might not be so aware of the swelling, but it's still happening and we still need to watch for it so that we're not causing harm to this patient's diseased cornea. Now, just to summarize, like I sort of alluded to, you will get 20 to maybe 50 microns in most patients. I think it was actually Dr. Lee who originally told me that the corneal surgeons she worked with, 50 microns was their cutoff, where they started to become concerned with the amount of swelling and start to make changes in the fit or the wear plan if you're having that much swelling. She's nodding her head yes, so I'm right, I guess. Good job. I listened in that class. Transplant patients, guys, by far the greatest risk. They're going to have a less robust endothelium, and so they're going to be at greater risk. And they're at greater risk for having a complication if they do have swelling. And we don't want to have complications with transplant patients. And remember that it's always a risk versus benefit. So you're going to get a little bit of swelling. But if the benefit is greater, then, we manage it. But, it's always a risk benefit ratio with these guys. So before I pass the microphone off to Dr. Lee, I'll just quick touch on one more quickie complication to just speed through here. Microbial keratitis. We talk about how there's not a lot of this talked about. We don't see a lot of infections with these lenses. I've made a table of all of the report. I think there's one more that just came out, but this was up to about 2015. There was about 10 cases of reported microbial keratitis. This little table here shows you kind of what they were wearing the lenses for. Most of these guys are this PED, right, an epithelial defect post-transplant. So these transplant guys are at greater risks, and certainly if they have epithelial defects, they're going to be at greater risks. Lots of them taking steroids, and certainly our risk factors for MK are going to be ocular surface disease as well as steroid use. And we always need to remember with these patients, more so than with any other patients, even though we should be telling all of them, make sure they have good lid hygiene, using their medications as indicated, when indicated, and taking good care of their lenses so that they reduce their risks for these issues as much as possible. All right. Anybody have any questions before Dr. Lee starts?
So we did get some good questions throughout the lecture so far. With patients who have deposits and maybe they're not having blepharitis, what is your typical solutions that you might want to go to? Should we maybe switch to Clear Care first or try Progen, or is there anything else we should try using?
Yeah, I usually will kind of do that sequence. So I will use Clear Care. And also the first thing I do, like I think Dr. Lee was saying to me earlier today or in this lecture or sometime, she watches what they actually do. So before you go jumping to all these, you know, crazy cleaners. Progen is fantastic. I use it all the time. I use Clear Care all the time. But if the patient's not using their regular cleaner well, they're not probably going to be super compliant with the other ones. So I'll usually say, show me what you're doing to clean it, because sometimes they're not getting the surfactant sudsy enough, so it's not going to break down the deposits. But yes, so certainly go to Clear Care. I use Progen, I think as often as about once a week in some of my heavy depositors. But first, make sure they're using whatever cleaner they have the right way, and then go to.
Making sure your patients actually rub their lenses is also very important. I think the only like no rub solution really is like the peroxide based ones. And so if they're not using that, they should definitely mechanically rub. Progen is awesome as long as you are dealing with a lens that doesn't have like a special coating like Hydropeg. If you do have a special coating on there, that might just strip the entire coating off. And so maybe your patient with really bad surface sweating paid extra for that coating, and now they just rubbed it right off of there. Another question that we got was, you know, how do you tell if there is hypoxia based off of the pachymetry? And so I think if we go back to slide 35, this one's perfect. Yeah, so, you know, I really love the Pentacam because it gives you a nice corneal thickness map like this. So instead of using your regular little pachymeter and just measuring one little spot, it gives you a nice map of the thickness throughout. And so you can compare all the different numbers. And so like Dr. Walker was saying, at UCSF, we kind of believe that 30 microns of swelling increase really isn't a whole lot. Kind of like if your IOP fluctuates, you know, 3 millimeters mercury here and there. Once you're seeing 50 microns of swelling or more, so looking at these numbers, some areas are borderline, some areas I would say are, you know, not really borderline. That's when you want to start thinking about decreasing the wear time or changing the fit to make sure that that eye is getting more oxygen. And we can talk about different ways to maximize the oxygen getting to the eye in one of our cases coming up. And so moving on from there, one thing that you want to think about all the time are your patients who maybe have autoimmune issues. This is a patient that I saw in San Francisco. I originally fit him for a scleral lens because he had rheumatoid arthritis. And so a lot of your patients with autoimmune problems, the first manifestation is going to be in the eye, whether that's just ocular surface disease or all the way up to a peripheral ulcerative keratitis, like how this patient had, which can then lead to like a corneal melt or perforation. And the problem when you fit these patients in sclerals is that they're so gosh darn comfortable. So the patient had this issue, and he just said, he came in randomly for a follow-up, and he's like, oh, you know, my eye's been a little bit red. I think maybe I scratched it a little bit. That's about it. But I put my lens on and I feel fine because it acts like a bandaged lens and just covers over this whole thing. But really, he was actually having an RA flare-up. And so he developed this large peripheral ulcer. You can see from all that staining there, right? And so immediately we had to, you know, stop the lens wear, up his meds a little bit. And so always, if your patients have some cyclosystemic issue and you're treating them with a scleral lens, let them know, like if there's any redness or decrease in vision, don't just blow it off thinking that it's just a mini little scratch or anything like that, because it could be something big like this, and you just want to keep an eye out for those problems. Now, moving on to case number 2, we had a 32-year-old Indian female who basically just came in. She was referred from Stanford. She had vision loss in both eyes. It was worse in the right than the left. She was saying that, you know, for years now, her eyes have been red and dry and really light sensitive. And she said her eyelids were just swollen. And this was probably the most intense case I've ever seen. She presented with a towel over her head because she just couldn't deal with light. She said that she slept with humidifiers all along her bed to the point where her husband couldn't even tolerate sleeping in the same bedroom with her because it was just so humid. In terms of her medications, she was trying a ton of different ocular meds that Stanford had put her on. Refresh PM every morning. She was using ketorolac as needed for pain. Rosacea, she said she couldn't use because it was just burning so much that she discontinued it. Lacrolube ointment she would put on at night, but she would put on so much ointment that it would literally cover her whole face, like she was totally shiny. And so in addition to the towel on her head, she also had this giant shoe box of drops, and she was wearing these really dark sunglasses to try to protect herself. And the pain was so bad that she was actually on a lot of oral medications as well to try to help with that. And one, thing that we kept in mind was that her sister kind of had this really strange, severe, like ABMD and ocular allergies as well. So maybe there's some type of genetic component going on with their eye issues that runs in the family. And so when we looked at her, it was so hard to get vision because she was just so photophobic. Right eye vision actually not too bad. Left eye definitely decreased. IOPs were fine. Pupils were fine. When we actually stained her, she definitely had a lot of conjunctival staining. It was really dense lissamine green staining. Looking at the cornea, this isn't actually a photo of her because she couldn't keep her eyes long enough for me to take a photo, but she had this really dense SPK centrally and superiorly. And when we checked her Schirmer's without anesthesia, really there was nothing. So just a really, really dry ocular surface. And so what me and the cornea specialists were thinking was maybe it's a combination of dry eye with SLK. Let's send her out and make sure she doesn't have lupus or rheumatoid arthritis or one of those autoimmune conditions that we have to think about, right? In addition to that, we're going to put her on these 7 eyes glasses that can kind of help with like any type of dust or debris or wind blowing at her that could dry her out even more. We wanted to start her on Lotamax gel 4 times a day for a week. She couldn't tolerate Restasis. Maybe she'll do better with Xiidra, so we can try her on that also. And then we're kind of a little loosey-goosey and told her, go to the store and try some different artificial tears and just try to find one that you're comfortable with. And when you come back, we're going to start you on your scleral lens fitting. And so in the meantime, she did come back. I fit her with a scleral lens. For the most part, the fit is not important here because she has a very normal ocular surface shape. It's just the actual ocular surface disease that she was having issues with. And so I put a diagnostic lens on her, ordered her something, told her, okay, lenses are going to take 2 weeks to get here. I'll see you in about 2 weeks. Well, 2 weeks did not go by. Instead, only 3 days came by, and she came back and she's like, I am not leaving until someone looks at me. I literally haven't slept for 3 days and I feel like a layer of my eye is ripping off. And it was just so dramatic and intense. And again, she came in, her entire face just covered in ointment. It was crazy. And so we had to, take a quick peek, and we looked at her cornea, and sure enough, on the left eye, she had now developed 3 large filaments, and there was just all of this diffuse, rough SPK everywhere. And so now we're thinking, okay, she really responded poorly to all the different drops that we've had her on. Maybe she's just having some type of toxic reaction that's just, really exacerbating this underlying dry eye. And so we kind of did something drastic. We said, okay, no more drops, no more ointments. We're just going to pressure patch this eye. And one really nice trick is to actually get one of those little Breathe Right strips and use that as a tarsorrhaphy. These are just the strips that you can buy at CVS to help open your nostrils for like the people who snore really badly at night. They work really well in terms of making a tarsorrhaphy. And so we also said to her, you might be one of those people where you're so sensitive to everything that we have to do autologous serum tears and non-preserved artificial tears only. And so let's pressure patch you and have you come back in 2 days and let's see what you look like. And so when she came back, she really didn't feel any different. She's like, my eyes still feel really, really dry. But when we actually looked at her conjunctival staining had improved greatly. And then in terms of the corneas, actually, there was still a faint patch of SPK, but the filaments were gone and all of that other diffuse staining was really gone. So for us, this was kind of like, okay, she definitely had some type of toxicity to all of those other drops that she was using. And so we wanted her to continue pressure patching. We started her on 50% autologous serum tears. And then again, we restarted the scleral lens fitting. And so after she got all the drops and whatnot out of her system and was using just the 50% autologous serum tears, we brought her back to continue with the fit. And again, the fit was actually quite easy, but what was really surprising was everything that I tried to fill the scleral lens bowl with burned and gave her issues. Whether it was Piri lens or just your generic sodium chloride inhalation solution. After that, we tried non-preservative free artificial tears. The only thing that didn't cause her ocular surface to flare up was her autologous serum tears. And we typically start with 50% autologous serum tears. And even with that percentage, she still felt mild burning. The only time she was ever truly comfortable where her cornea cleared up was 100% autologous serum tears. And so now, at least when I left UCSF, she was comfortable, her corneas were clear. However, she had to get her blood drawn basically every week to get this serum made for her eyes, and she was becoming iron deficient. And so that was something we had to send her to the PCP for, and hopefully they figured it all out because I'm pretty much no longer there now. But the summary here for this case would be, not all scleral lens filling solutions will work for all of your patients. This is a really rare example of needing to go all the way to the extreme 100% autologous serum tear filling solution. However, you know, for our other patients, if they're having issues with maybe the boric acid buffer in PuriLens, consider a preservative-free and buffer-free solution like your sodium chloride inhalation solution. And then from there, if they're still having issues, then consider going to like a non-preserved artificial tear. And of course, what we're really excited about is all the different specialties scleral lens filling solutions that everyone is researching right now. Hopefully they find a good recipe that will work for most of our patients. This is another complication that I saw in San Francisco. This patient basically came in with really bad allergies that we had fit in sclerals, and she said she was doing fine. When she came in, her eye looked like this. It was really gunky. There was a lot of mucus and whatnot underneath the lens. And then when I asked her how long she had the lenses in for, basically she hadn't taken them off for 3 days. And so it was kind of really gross. If you ever have a patient come in looking somewhat like this, always ask them about their wear time. If it's, you know, after 6 hours or 5 hours, it might be something that you have to troubleshoot a little bit more, adding allergy eye drops or oral meds or whatnot to help control all of this mucus buildup. Our third case is a 60-year-old Caucasian female. She came in again, you know, had transplants done in both eyes due to keratoconus. She was wearing GPs at the time. Vision for the most part was okay, but she felt like they could be improved further. At that time, she was using FML 0.1%, 1 drop in both eyes every day, just to kind of keep her transplant from rejecting or failing. And then in addition to that, she was using preservative-free artificial tears as needed throughout the day. And so anytime I start to think about fitting a patient who's had some type of transplant done, there's a lot of necessary baseline information that I want to collect to prevent any issues from happening. So first and foremost, a really good history of that corneal graft. Why did they get this done? Typically, if your patient gets a transplant because of keratoconus, they tend to last the longest, as opposed to a patient who got a transplant done due to Fuchs or other conditions like SJS or things like that. How old is the transplant? Because we know they don't last for forever. And this is one of those things that I really tell my patients about before really referring them out, because some patients come in thinking, you know, I'll get 1 transplant, I'll be 1 and done, I'll never need a specialty lens ever again. But we all know that that's not true. And a lot of times they end up needing another transplant, and they still need to be fit in specialty lenses after the transplant is done. What kind of transplant is done? You know, back in the day, we were doing a lot of full thickness transplants, even for our keratoconic patients. Nowadays, as the surgical techniques are getting better, we're actually starting to see more partial thickness transplants, whether it's just for Fuchs and they're taking off that back layer, or if it's keratoconus and they're taking off the top 2 layers. And if your patients had any prior rejection episodes, right? Because once a patient has a rejection episode, the chances of them having another one are actually pretty good. And so another thing I like to get, of course, is your endothelial cell count. Get a good pachymetry reading, baseline pachymetry reading, especially so we can monitor for hypoxia. IOPs are so important in these patients because a lot of times they end up on steroids for long periods, and they won't see their surgeon much, you know, after they're released. And so you'd be surprised how many patients walk in and their IOPs are like in the 30s and they have no idea. Then you have to kind of change gears a little bit and add, like, you know, glaucoma drop or other things like that as well. And of course, take some baseline photos so that it's easy for you to kind of monitor what that eye looks like year to year.
I just want to make a quick comment because I saw that Rob had said I think it was Rob, you know, based on having pachymetry through the pentacam, if you're taking that with a transplant patient, does that really give you the information about whether or not a patient's going to swell? And do you need to be looking at the endothelial cell counts in those? And I think that's a good question. So basically, you know, do you have to look at endothelial cell counts, or do you just see what happens with the thickness and base them off that? So it's kind of a loaded question. So I would say if you have both instruments, do both. Certainly you can potentially predict with a specular microscope how a patient's going to do hypoxically based on what their endothelial count is. Real world though, and I don't know about you, Dr. Lee, the worse an endothelium is, the harder it is to get an actual image. So honestly, most of my patients, like in this image, I don't know how that even recorded anything on that left eye, but most of my patients who are at greatest risk, if they're severe keratoconus, if they've got a shoddy looking transplant, it's going to be really hard to get the endothelial image anyway. So yeah, I generally will use that more as a teaching tool for the students, but I really go on based on pachymetry and whether or not they actually swell when I put a lens on.
Yeah, completely agreed. And honestly, just remembering that despite it being a successful surgery, you know, 5 years after that transplant is done, you still are going to lose around 50 to 75% of the endothelial cells that you have, because that's just the nature of what happens in these type of procedures. And so this case actually kind of talks a little bit about what Rob is wondering about too, because the right eye, the endothelial cell count is alarmingly low, 583 cells per millimeter square. The left eye, I'm not as worried about. We have like about almost 2,000 cells per millimeter square. And so technically, they usually tell us, you know, once that eye has less than 800 cells per millimeter square, you really want to start monitoring for swelling. And so we have our pachymetry. I usually take the thinnest point from the pentacam and I record that under my pachymetry area, but really I'm relying on my map as well. IOPs looked fine, so really wasn't worried about any type of ocular hypertension or glaucoma from her steroids. And so when you're thinking about optimizing the lenses, and we kind of touched upon this earlier, especially with your transplant patients, always maximize that oxygen, keep your lens thickness in the center as thin as possible, utilize those high DK materials, and when you're deciding on an apical clearance, try to keep it low, like under 200 microns if you can. Also, because this patient has an oblate shaped cornea, think post LASIK or post transplant, consider using a reverse geometry design. The photo on the right, these are actually all different types of bridges that exist in the world. And so, we're scleral lens obsessed, and we kind of think about sclerals everywhere we look. And so think about, going from a Parker design and going more oblate to like a Baltimore design in that middle section. So really flattening out the center so that you keep your apical clearance low, and then going a little bit steeper in that limbal area so that you still clear the limbus and you're basically aligning nicely if you can. And then of course, emphasis on haptic alignment. Balance out the weight of this lens so that it's not particularly harsh in one area and causing a lot of blanching. Ideally, it's going to be nice and balanced out, kind of like a snowshoe in the snow versus a stiletto high heel in the snow, where it can cause a lot of issues on that conjunctiva. And so the main takeaway here is, for my trial lens parameters, I started with a reverse geometry design where the limbal curves were steeper than the base curves. Center thicknesses were a little bit on the higher end, and so we went with a more breathable Boston XO2 material. After looking at this fit for about 30 minutes or so, our lens apical clearance was around 0.75 center thickness, so still a little on the higher end. For the right eye, the limbal clearance kind of thinned a little nasally. The lenses dropped a little bit. For the left eye, kind of the same thing, but there was more lens drops, so they had a little bit of nasal mid-peripheral touch and limbal touch nasally as well. However, her main complaint was that blurred vision, and so we could clear up her vision just a little bit, especially with an SCOR in that right eye, whereas she was seeing 20/30 earlier. And so, you know, main idea here is there's definitely some room for improvement, especially with the fit. And so we made some changes. We ordered the lens, dispensed them to her, and she came back for a 1-week follow-up with her lenses on. And so this is kind of what she looked like. Hopefully the video is working for all of you. And so for the most part, you know, the right eye was fine. 20/20 vision, good fit, vision comfort, and ocular health, no issues there. And that was the eye that actually had the low endothelial cell count. Right? So we can't always, you know, assume that the eye with the low endothelial cell count is going to have the issues. The left eye had almost 2,000 cells, and her, you know, that eye vision was a little bit decreased, 20/30-ish, at least through pinhole. It's like 20/20 minus, so okay, not too bad. Maybe that vision is a little bit decreased because the lens is still dropping. Do we think there's hypoxia going on? We checked the chemistry readings. Honestly, it's about the same, so probably not a hypoxic issue. So let's keep looking at this lens fit. And when you look at the bottom of the lens though, so subjectively, the patient really had no pain, no discomfort, no injection. But down below, we do see that because the lens is dropping, there's a little bit too much limbal clearance. There's some conjunctival prolapse, but there's also a little extra pouch of tissue almost, it looks like, especially in the host tissue. And so, okay, what is that? Let's take the lens off and really get a closer look. Oh man, okay, so sure enough, we removed the lens. This is not what I was hoping would happen, but it happened. We have 3 pretty large corneal bullae. She's not really having any problems right now, at least in her mind. She's pretty happy. Is it Fuchs? Maybe. I mean, she's kind of an older Caucasian female. Maybe she's having some Fuchs in her host tissue. But her original reason for getting that transplant done was keratoconus, right? Could it be due to trauma? She definitely had sutures there before. They were all pulled and removed, but just having those sutures there possibly could have caused some endothelial trauma, and especially because, you know, the transplant was placed in that area as well. Is it scleral lens related? I kind of think so. There was a lot of limbal clearance, especially when that lens was dropping down. And so we have to tackle some of those issues. And are we actually concerned about any of this? Well, yes, because if these bullae rupture, that's going to be very, very painful for her. It could potentially lead to ulcers or even an infection. And so we have to tackle this and try to keep this from happening. Now, one interesting thing is I've talked to some of my other colleagues who have seen this before, and none of us have actually had any of these bullae rupture, which is, I guess, positive, right? I mean, I'm really glad, but I also don't want to be that one doctor who has the first one pop on them. And so whenever I do see these, I definitely want to improve it. Now, some of the other things that I'm thinking about keeping in the back of my mind, because she is a patient that had a transplant done, is I don't want to see rejection and I don't want to see failure. Now, rejection is essentially when your host or your body starts to recognize that donor tissue. Because she had a full thickness transplant done, you know, this can occur in the epithelium, the stroma, or the endothelium. If you think you're seeing rejection happen, you want to treat aggressively with steroids, followed by a slow taper. I usually will treat with steroids, send them back to the surgeon. Surgeon will follow them, and they're not going to say that, you know, that they failed until they've tried at least, you know, steroids for 4 weeks and the patient just hasn't responded. Then once that graft fails, they'll have to end up, you know, with another transplant. And so my initial management changes, first and foremost, was just decrease the wear time a little bit, take her down from the 10 to 15 hours, more to like 6 hours maximum. I added Muro 128, 5%, 3 times that left eye to try to help just draw some of that fluid out. And we can see it kind of helped a little bit. That third one is a lot flatter now, but we still have the 2 larger ones there. And so in addition to this, while we were waiting, I started to incorporate some changes into the lens design as well. Now, to help with all that lens drop, I added in a toric periphery. I also flattened the peripheral curves just a little bit because I felt like they were just a little too harsh on the eye. The whole goal there is, one, improve centration and maybe increase the tear exchange. And so from that first change already, we can see, okay, the 3 giant bullae no longer really there. However, it's kind of migrated, and we have like a little cluster of smaller ones. So at least I feel like it's still somewhat improving just a little bit based off of the decreased wear time and the parameter changes. And so in addition to this, afterwards for my next pair, I also went a little bit larger, and I increased the optic zone diameter, I flattened the base curve, and I steepened my limbal curve. So essentially all I really did was I increased the reverse geometry design, right? Decrease that apical clearance, still clear my limbal area. And so with that final third pair, we can see now she's actually nice and flat again. And so by aligning to the eye just a little bit better, we kind of made those bullae go away and helped with the lens drop and all of that. And so that was one of my more unexpected complications that fortunately turned out fairly successfully. Any questions at this point? Because that's essentially our last slide.
We've got a few questions here, and they're coming in. In regards to tear exchange, how much is really desired under a scleral lens?
Oh, Karen's looking at me. I'll take that one. That's a good question. So what I tell people, or tell students and patients, you want slow, moderate tear exchange. So I actually had a patient this morning who was getting too much tear exchange. And if you have areas where the lens is too far away and the fluid's kind of flushing in and out, you're going to get little teeny bubbles that come in because the patient's going to blink and it just kind of churns everything, and it'll cause a lot of tear exchange, but also little bubbles. Patients will also get debris, and the lens is usually moving. So what I like to see when I do it, and what I do to test it, is put fluorescein after the patient's been wearing a lens for a while. Put fluorescein on the conjunctiva and watch to see if it goes under. Within a minute, I want to see a little bit of that fluorescein start to percolate under the lens, so that I know I'm getting some exchange and some mixing of those tears. But when I see too much kind of rushing in, it's usually associated with some negative sequelae.
Yeah, I agree. Like, you can tell, like, if a lens is moving a lot when the patient is blinking, they're going to have almost excessive tear exchange. Or if you have an area where the haptic just really isn't aligned to the eye. And I like to do that little trick as well too, especially with my patients who have like a lot of debris or a lot of midday fogging issues. I'll, just dab some fluorescein there and try to find the area that's just not aligned. And usually you'll see like a little green channel just of fluorescein flowing in, and you're like, okay, that's the area I need to tackle and fix. But otherwise, there's a lot of research going on right now. They're still trying to figure out a good way really to measure tear exchange with scleral lenses because they're so different from GPs and your typical soft contact lens.
We've got about a minute left. There's been a few questions on recommended follow-up schedules for transplant patients under scleral lenses.
So
go ahead, Maria.
Well, yeah, I'll quick and then you can do it. So I don't specifically have transplant follow-ups. I follow all patients the same, which is I'll see them a week after dispense to see how they're doing. I will then see them a month after if they're doing well. Of course, if you have issues and you need to refit and patients have a red eye and yada, 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 there's always things. Then they're going to have to come in as these things come up. But with a well-fitted, relatively healthy, not making the eye worse kind of health, I see a 1 week follow-up, a 1 month, and then anywhere from 3 to 6 months. Depends on their risk. If they're on their third transplant and they're on steroids and glaucoma medications and, are at risk, then yeah, I'm going to see them after 2-3 months. But a lot of what I'm doing is really just educating those patients. These are the signs that something's wrong. Come and see me if there's an issue.
And you can kind of tell, like, the stage that your patient's in. Don't ever be afraid to see your patient more regularly. Like this one patient that I had where she was monocular, and she had her second transplant done, not a lot of endothelial cells. I had her put a diagnostic lens on where I felt like the fit was pretty good. Did an overrefraction of -5, grabbed a -5 daily disposable lens, threw it over top so she could kind of walk around and at least see something. And she hung around for like 4 hours And after that 4 hours, we took the lens off and we measured her thickness again and checked her VA again. And unfortunately, that patient actually ended up swelling a lot after 4 hours. And so she just wasn't a good candidate for sclerals at all. And so if you think you need to see your patient a little bit more regularly, that's absolutely fine too.
And we'll do one more here. There's a number of questions about amniotic membranes and their relationship with scleral lenses. Do you guys have experience with utilizing amniotic membranes under scleral lenses or amniotic membrane drops, excuse me, for ocular surface disease patients?
So amniotic membranes, we actually just did one like this past weekend. Love them, dehydrated or not dehydrated, they're awesome. I personally don't mix and match a scleral with an amniotic membrane. The surgeons that I work with, they're big advocates of taping the lids shut after you put the membrane on, whether it's the Procera or the BioDisc D or the AmbioDisc. You know, put that membrane on. Patient's not going to see well through it anyways because it's just so hazy and foggy. If any of you have ever tried a lens on when the person came to your office to demo it, they're not going to see well. So just tape the eye shut, keep it nice and moist, and honestly, that really capitalizes on all of the healing effects that your patient can have. And honestly, keeping a lens in for more than 24 hours is not the best idea, especially if you think they're needing a membrane for something. You know, after you heal them up, then consider going back to the scleral. I think that's a really good combination.
Yeah, I for sure have never and would never use them at the same time. However, what we do with more and more increasing frequency is a patient comes in with a really bad looking eye because of ocular surface disease. So we'll pre-treat them with the membrane. And then once we get the eye to the state, you know, and it's usually well is good enough because they're not going to look like a normal eye. We get them to a place where we're comfortable, and then we use the scleral lens to maintain the status. And oftentimes we're using autologous serum drops in the bowl. And I saw somebody asked about percentages, like Karen talked about. You know, we start with 50, you work your way up, depending on if the patient responds well. So yeah, sure, use them together all the time, but I don't stack them on top of each other. It would be logistically, I can't imagine a lens would even be able to be supported over the top of a Procera, maybe an AmbioDisc. But
yeah. Well, it looks like we are out of time. I want to thank everybody for coming tonight, and thank you, Doctors Walker and Lee, for a fantastic lecture. We did get this course COPE approved, so expect an email in the next 24 hours-ish with information on the quiz that'll be required to get COPE credit for this course. Also expect a survey coming separately that we'll need you to fill out, rating the course that we also use to submit to COPE. We'll have another Scleral Lens Education Society webinar coming up on October 16th with Langis Michaud and Justine Sergi on fitting complicated refractive errors and the use of technology to aid scleral lens fitting. Again, thank you all for coming out, and we'll see you back in a couple months.
Thank you for listening, guys. Have a good night.
Thanks, guys.